This conference will now be recorded.
See, this is the intersphincteric space. Intersphincteric anal glands, if they get infected, it will form an abscess. So after abscess, what happens? There will be pus draining out. So where will the pus go? The pus will obviously go to the dependent portion. Obviously go to the dependent portion. From here, through the septa, along the septa, the pus will trickle along the septa and gets collected here in the perianal space. So the most common abscess will be the perianal abscess, because due to the pus draining into the least resistance area and the dependent part. Okay. So the course of spread is perianal, and the spread of the pus can go into the ischiorectal fossa. See, here you can see a transverse septa. Okay, a transverse septa arising from the longitudinal muscle, separating the subcutaneous part of the external anal sphincter and the superficial part of the external anal sphincter. Between these two parts, this transverse fibrous septae will be going into the ischiorectal fossa. Okay, so this is the base of the ischiorectal fossa. So either the pus can be going like this through along this septa, or it will be piercing through the external anal sphincter. Okay, external anal sphincter through some fibrous septa and enter into the ischiorectal fossa. Okay, that is one type of spread. And another type of spread is there may be a extension into the supralevator space above. There may be extension into the supralevator space also. Okay. So not only in the course of spread is the perianal, ischiorectal, and supralevator. Among these three, the perianal and ischiorectal are the most commonest spread. Okay, most commonest sites where it will be where there will be a spread from the intersphincteric plane. Okay. Next is the so the pus may not be present on one side. Okay, the pus may not be present on one side. It can go circumferentially. It will go circumferentially, or it may be present at one side, or it may be going along the anococcygeal ligament behind the posterior to the anal canal, and may go and reach the opposite side, contralateral side also. Okay, so I have told you in the previous class, such abscess from the ischiorectal fossa of one side to other side, if it goes beyond posterior to the anal canal, then it will form a horseshoe, a U-shaped abscess. Further, it will result in horseshoe-shaped fistula also. Okay. So that is the cryptoglandular theory. So non-cryptoglandular or specific causes. So the infection can occur at the same sites or various sites. So due to the causes of non-cryptoglandular, so I have listed out the causes for the non-cryptoglandular. These may present in the ischiorectal space, perianal space, or the supralevator space, and it can be present in other sites also, that is submucous space, marginal space, and the intersphincteric space. Okay, so example for a submucous space. So I have told you at the mucocutaneous junction, in the submucous space below the mucosa, in case of a hemorrhoids, for suppose example of a hemorrhoids, first degree hemorrhoids, or an early degree second degree hemorrhoids. So what you do is, the primary mode of treatment is you give an injection sclerotherapy. You will give injection sclerotherapy for first degree hemorrhoids or a early second degree hemorrhoids. So once if proper precautions are not taken properly, or if while giving injection, if there is a formation of a hematoma in the submucous space, that will result in a abscess formation. Okay, that will get infected and form an abscess formation, and it will result in a submucous abscess. That is an example. Okay, next is the marginal or mucocutaneous abscess. So I have shown you, there are near the margin of the anal canal, mucocutaneous junction, there are lot of external hemorrhoidal plexus, external or inferior hemorrhoidal plexus. You can see in this diagram. Okay, external, this blue thing. So if that vein get if the vein get punctured and form a collection of blood here, it will form a clot. So if that hematoma gets infected, it will develop into an abscess. So it is called as marginal space abscess or a mucocutaneous abscess. So in the ischiorectal region also, there may be some specific causes which causes abscess formation in that region. So number one is foreign body. For suppose while walking or while cycling, the person had a fall from a bicycle, or if he got poked with some sharp object like some nail, so what happens, it will be going into the ischiorectal fossa, and there it will form a foreign body. Foreign body will go inside the ischiorectal form and form a abscess cavity. Okay, so one is foreign body, another is trauma, and if any deep seated skin infections are there, it will also go into the ischiorectal fossa. Okay, so next is the supralevator. So supralevator abscess, apart from the cryptoglandular theory, there are some causes where the supralevator infection also occurs. These are the, see supralevator region, it is very close to pelvis. Can you see here? Supralevator space is very close to pelvis. So in the pelvis, what are the other structures? You will see there will be what pelvic gynecological disease or uterine disease, pelvic inflammatory disease. So any disease in relation to the gynecological cause, it may spread to the supralevator space. Okay, so any pelvic disease, appendicular if any appendicular abscess also may trickle down into the supralevator space also, or any gynecological cause also may cause that infection may spread into the supralevator space. Okay, so other are the, if any malignancy in the rectum, or if there is any Crohn's disease, that also may cause a supralevator abscess. Okay, so the other general causes are the diabetes mellitus and the AIDS. Okay, so these are the causes of the non-cryptoglandular causes for the anorectal abscess. So what are the clinical features? The most common I have told you, the perianal abscess. The patient usually, to our surgical outpatient department, a patient comes any age. Usually it is between the 20 to 50 years or 20 to 60 or 70 years also. So any patient who comes with a complaints of, sir, I am having some pain around the anus and I can feel a small swelling around the anus of very short duration of 2 to 3 days, of 2 to 3 days. So pain will be of throbbing type of pain in case of a perianal abscess, and the patient complains of fever also. So on examination, with the patient in lithotomy position or left lateral position, you can see a swelling well localized, which is well localized in the perianal region, where you can feel warmth, where there will be local rise of temperature over the swelling. The swelling on touch, it will be tender, and on appearance it will be red in color due to inflammation, and there will be some induration. So all signs of inflammation will be there, dollar tumor. Okay, all signs of inflammation will be there in case of a perianal abscess. And then you can also feel there will be softening at the center of the swelling. That softening is due to the collection of the pus, and that is due to the stretching of the skin, and it will be about to burst, so that softening will be there. Okay, that middle part of the swelling, there will be thinning of the skin, so you can feel the softness underlying. There will be loculated pus will be there. Okay, so that is the perianal abscess clinical feature. So how does the patient with the ischiorectal abscess? But the ischiorectal abscess, if the patient comes with an ischiorectal abscess, he will just have a deep pain. Okay, he will have a pain, but it is not more when compared to this perianal abscess. There is some reason, because see, in perianal abscess you can see in perianal abscess there is lot of tissue tension will be there. There will be lot of tissue tension, because see here there are multiple septa are there. Okay, so the pus will be getting entrapped here, and the pus has no drainage or no space to move either side, so it has to come out of the skin. So there will be tissue tension developing within this space. So it will try to come out of the skin by bursting out. So due to the stretching of the skin nerve endings, the patient will have a lot of pain. Whereas see here, it is a wide space. Ischiorectal space is a wide pyramidal space. See, if you have some abscess cavity here, patient will not have pain because there is no tissue tension over here. There is no tissue tension here because it can move from here to this side, or it can move in this space only. So patient will not have much amount of pain, but due to the deep seated abscess in the ischiorectal space, patient will have fever more than pain. Okay, so that is the delayed presentation. So in perianal abscess, it is a early presentation, short duration between 2 to 3 days. Patient of ischiorectal abscess usually present with 1 week or above. Okay, the patient will have more of a fever than a pain. On examination, you will see when the patient present, there will be a diffuse swelling will be there. There will be induration will be there. When you palpate the ischiorectal fossa, there will be deep tenderness will be there. Okay, it is not a well localized swelling. So next is the supralevator. What are the symptoms of a supralevator abscess? This is also very difficult to diagnose a supralevator abscess, but patient will give some pain in the deep rectum. Sir, I am feeling some pain somewhere in the region of the anal canal, but he will not able to tell that there is a swelling or not. Okay, so patient complains of fever, there will be pain, and because it is supralevator region and it is very close to the pelvis, the surrounding pelvic organs will also be irritated. So surrounding pelvic organ is bladder. So urinary bladder if get irritated, there will be frequency of micturition. So patient will have some micturition disturbances. Okay, next is on examination, supralevator region you can't examine externally. Only you can see the anus and perianal or ischiorectal region. But supralevator space is very deep, so you can't. If the abscess forms in the supralevator region, externally you can't see anything. But per rectal examination, if you put a finger in the rectum, anal canal and the rectum, supralevatorly, just if you feel the anorectal junction, that is 5 centimeters above the anal verge, if you put a finger, you can see some induration, swelling. You can see some boggy swelling in the supralevator above the anorectal junction. That will get, and if you press it hardly, patient will have tenderness. That will give you a diagnosis, suggestive of diagnosis of supralevator abscess. Okay. So how do you manage? So management of anorectal abscess, any abscess in the body, the management is surgery, only surgery. The abscess is, the treatment is anywhere is incision and drainage. Okay. So before doing the incision and drainage, this you should not be doing under local anesthesia. Okay. It has to be thoroughly examined. It has to be given under spinal anesthesia. It has to be taken to the operation theater. Patient is kept in the lithotomy position. If required, a proctosigmoidoscopy can be done. Next, what you do is, if it is a perianal or an ischiorectal abscess, you give a cruciate incision. Cruciate incision means plus mark, plus shaped, plus tells kada, plus longitudinal transverse, joining those two. If you give a plus shaped incision, you will form 4 flaps, skin flaps in the 4 quadrants. Okay, so those skin flaps should be deroofed. That is, you should cut the skin flaps. So then you will get a diamond shaped wound will appear. Then in that wound you put a sinus forceps. You put a sinus forceps and open the blades of the sinus forceps and remove it. Then there will be pus gushing out of the wound. That pus you send for culture and sensitivity. And the tissue from the wall of the abscess cavity also you send for histopathological examination. Okay. After that, what you do is you will put a finger, gloved finger, gently into the wound cavity, and gently you need to break the locules. So abscess cavity, usually there is no, within the abscess cavity there will be multiple septa will be there. Within that septa there will be collection of pus will be there. So you have to put the finger into the abscess cavity and you have to break all the septa. So if you break all the septa, the pus will come as a whole, it will come out without leaving anything. So till at what step you have to stop? Till the fresh bleeding has appeared. Till the fresh bleeding has appeared. When you break the locules, pus will come. After that, you will have a fresh bleeding. At that point, you need to stop, because if after that also if you start putting your finger and you just manipulating the ischiorectal fossa, there may be a chance of injury to the vessels. So gently put a finger and break the locules, break the septa, pus will be drained out, and there will be followed by a fresh bleeding. There you stop the procedure, give a thorough hydrogen peroxide and saline wash within the wound cavity, and now you pack the wound with betadine soaked gauze piece and do a put a sterile pad and apply plaster. Okay, that daily you should be doing dressing post-operatively till a healthy granulation tissue comes and the pus is subsided under an antibiotic cover. Under a good antibiotic cover, you need to put a metronidazole or cephalosporin. Okay, broad spectrum antibiotic should be kept. Okay, so you should look for an underlying fistula. So you can, with the help of the pus culture and sensitivity, you can say that whether there is an underlying fistula or not. How is, see, if there is a pus, so you can say, see, in the perianal region there are hair follicles. So in the hair follicle there may you may get folliculitis or a boil also. Okay, so you in the pus culture incision, if you take, if you think that if it is a perianal abscess mimicking that of a boil folliculitis, if you give an incision and you have removed the pus, you send for culture and sensitivity, and in the culture and sensitivity you will get an organism. If it is a skin organism like a staph aureus, so then you can say that there will be no underlying fistula. If the pus culture and sensitivity, you have given incision and you have collected the pus and sent for culture and sensitivity. If the pus report, culture and sensitivity report comes as Escherichia coli, then you should suspect that there is a connection to the anal canal or the rectum. Okay, and there will be an underlying fistula. Okay, there will be an underlying fistula. So if there is an underlying fistula, you can do a set on or a fistulotomy at the same sitting. Okay. So next is the supralevator abscess. So here is the supralevator abscess. I have told you this cannot be seen externally, but if you put a finger inside, gloved finger inside, and you can palpate the supralevator abscess, because there will be, due to distension, there will be some boggy swelling here. You can palpate with the finger inside the rectum. This is due to the push of this abscess. It will form a swelling inside the rectum. Okay. So what you can do is, under guidance, you can put a wide bore needle. You can put a wide bore needle and puncture this area where there is more fluctuation, more prominent fluctuant point. When you palpate with the finger, there you poke the swelling with a wide bore needle. So what happens? Due to dependent drainage, the pus will come and drain into the rectum and will come out of the anal canal. This is the intrarectal drainage of the abscess. Intrarectal drainage of abscess. So this is one method, and another method is, you can do a ischiorectal. You give an incision, cruciate incision. You put a finger inside and you break this one. Or put a sinus forceps directly here through the levator ani and open it. So after opening, there will be a pus coming out from the supralevator region to ischiorectal region. So from here to here it will drain out, and here you will clear the pus from the ischiorectal region. So these are the two methods, either by skin incision of the ischiorectal region or by giving a poking the swelling with a wide bore needle and draining the pus from the rectum through the anal canal and outside. So these are the true ways of drainage of the supralevator abscess. Okay, this is the topic of anorectal abscess. Okay, very short topic, but very important. So next is the fistula in ano. Okay, so anorectal abscess. Why first I have discussed anorectal abscess is because fistula, to form a fistula, first abscess should form. Fistula will not occur by itself. Okay, fistula will not occur by itself. It has to be preceded by an abscess which have been inadequately drained, or it has been spontaneously ruptured by itself, and it forms an incomplete tract. Okay, incompletely, if it has been spontaneously ruptured or incompletely it has been drained by the surgeon, it will form a fistula. Okay, so always to form a fistula there should be a previous, definitely the patient, if you ask the history, సార్ నాకు ఇక్కడ నుంచి పక్కన నుంచి మోషన్ పక్కన నుంచి కారుతుందండి అంటాడు. పక్కనే మీకు ఇంతకు ముందు ఏదన్నా అక్కడ వాపులా ఏదన్నా ఉందా లేదా అని అడిగారు అనుకోండి, డెఫినెట్ గా ద పేషెంట్ విల్ టెల్, ఎస్ సార్, ఐ గాట్ ఏ స్వెల్లింగ్ సమ్ 1 month back. I got a swelling over the perianal region which got bursted spontaneously by itself, and after 1 month of duration there occurred a small opening near the perianal region. From there I am feeling that there is a discharge of pus and blood mixed along with it coming out through the opening. That is the classical presentation of a patient with a fistula in ano. Okay, so now we will discuss this topic under the side headings. So number 1 is definition, number 2 etiology, what are the clinical features, how are the fistulas classified, what are the findings you see in a case of a fistula in ano, clinical examination, investigation, and management, surgical management. Okay, so coming to the number 1 is the definition. So what is the definition of a fistula in ano? Anywhere fistula, there will be two openings, either there is internal and external opening, and in between the internal and external opening there will be a communication or tract. Okay, communication or tract. So in case of an anal fistula, see here you can see an anal fistula here, and I have given an example of a simple anal fistula and a complex anal fistula. So here you can see the internal opening is present here. Here also internal opening is present in the anal canal. Here you can see at the dentate line. So there is an internal opening inside, external opening outside. External opening is usually at the skin of the perineum or the skin of the buttock. Okay, internal opening usually in the anorectal lumen. Okay, so the definition is, it is an abnormal communication or a tract which is, this tract is lined by granulation tissue. It is lined by granulation tissue connecting two openings, that is internal opening and external opening. So internal opening being into the anorectal lumen and external opening being into the skin of the perineum or the buttock. Okay, this is the definition of a fistula in ano. Okay, so what are the causes? See here also I have told you, in anorectal abscess also I told you there is a etiology, two etiologies. Number 1 is the cryptoglandular and the non-cryptoglandular or specific causes. Here also in fistula and ano, the causes are the non-specific, idiopathic, or cryptoglandular. This is the most common cause. So specific causes are not common. The most common cause for fistula in ano to develop is the cryptoglandular theory or the non-specific theory, non-specific cause or idiopathic. Okay, so what is the cause is, there will be intersphincteric anal gland infection. See, intersphincteric anal gland infection, till now no one has known how the anal gland infection occurs, but usually అంటే పేషెంట్స్ ఎలా ప్రజెంట్ చేస్తారంటే, నాకు వేడి చేసిందండి అంటారు. సో anal gland ఇన్ఫెక్ట్ అవ్వాలంటే పేషెంట్స్ కమ్ టు ద సర్జికల్ ఓపీడీ, దే విల్ కంప్లైంట్ దట్ సార్ నాకు వేడి చేసిందండి, వేడి చేసిన తర్వాత ఒక వాపు వచ్చింది, ఆ వాపు చితికిపోయి ఇట్లాగా ఓపెనింగ్ ఫామ్ అయ్యి అందులో నుంచి పస్ వస్తుందండి అని అంటారు. మోస్ట్ ఆఫ్ ద పేషెంట్స్ వాట్ ఐ హర్డ్ ఈస్ డ్యూరింగ్ ద ఓపీడీ దే యూస్ టు టెల్ నాకు వేడి చేసిందండి, వేడి పదార్థాలు తిన్నానండి, అవన్నీ చెప్తారు. So that's why no one has not found a cause. That's why it is called idiopathic. But they think that there is intersphincteric anal gland infection is the main cause for this, for fistula to form. Okay. Next is the specific causes. Next are the specific causes. So specific causes. So it fistula in ano may be caused by some Crohn's disease, tuberculosis, actinomycosis, lymphogranuloma venereum, rectal duplication, foreign body malignancy. Okay, these causes you need to remember. Okay, the most common in our region India anukunte ganaka most tuberculosis. Okay, some after that you can go for Crohn's disease, but actinomycosis, lymphogranuloma venereum, these are very rare. Okay, but malignancy and foreign body are also somewhat more common, but only after tuberculosis and Crohn's. Okay, so these are the specific causes of fistula in ano. So what are the clinical features? So how do a patient present with a fistula and ano? So mostly to our surgical OPD, males will be coming. Only men are not only men, when compared to female, are more prone to develop a fistula and ano. Okay, but females are also exposed to get this fistula, but we see in the surgical OPD more men. Okay, and the age group is between the third to fifth decade. So usually I told you the patient will come to the OPD, sir naku motion area దగ్గర పక్క నుంచి చిన్నగా రసిలా కారుతుందండి, చీమలా వస్తుంది, అప్పుడప్పుడు రక్తం కూడా వస్తుందండి అని అలా ప్రజెంట్ చేస్తారు. So they will complain, అది కూడా they will not tell that continuous discharge, there will be intermittent. Why intermittent is, see that tract is there, no, sometimes it will get closed, and it will form an abscess. Okay, it will form an abscess, and by itself it will drain by itself, and it will discharge the contents through the external opening, and the patient will get relief of pain. Okay, so that's why in a patient who comes with a fistula and ano, patient will say that I don't have pain, because the pus is freely draining from the external opening. So patient will not complain of pain, but sometimes that external opening will get blocked. So what happens, the tract will secrete some secretions, that secretions will be within the tract, so internal and external opening are closed. So due to tension the patient will have pain. So what happens in a due course of time, that secretions will get discharged from the external opening by the opening of the external sinus. So once the secretions have been drained, patient will get relief of pain. So that is the typical character of a fistula and ano, that is intermittent episodes of passing pus or blood through the external opening, and the patient, for a fistula and ano, patient will not have pain. And if you take a past history, patient give you a past history of anorectal abscess, there is a swelling, sir, in the perianal region, for which I underwent some surgery. He may, if a correct surgeon performs a incision and drainage for an perianal abscess correctly, what I have said previously, by giving a cruciate incision and deroofing of flaps, then the chance of getting a fistula and ano in the future is very less, that is 5 to 10%. If we go to some RMP or local quack, and if we get undergo some surgery, he will not do completely, he will just give a nick and he will leave it like that, he will not do dressings also. In such cases what happens is, there will be a chance of fistula formation is 80 to 90%. Okay, that's why I have here told you there will be a previous episode of anorectal abscess which have been incompletely drained through a surgery, or it is, the patient will not go to anyone, but the abscess will get discharged, spontaneously ruptured by itself, and it will drain the pus by itself. So in such cases also there will be thinking of inflammatory swelling. So if due to antibiotics also some amount of the pus will be treated, but some amount of pus will be residual pus will be present within the anorectal region, and it will form a fistula in a future date. Okay, so those are the clinical features. And if you see through the external opening, if there is a passage of flatus or passage of feces, stools coming out from the external opening, you should think that it is not an anal fistula, it is a rectal fistula. Only rectal fistula, there will be passage of the flatus or the feces from the external opening. Okay, so classification, this is very important. This is very important, and you should remember the classification. There are some simple general classifications, and there are some specific classification is there. This is the high or low anal fistula. See, high or low anal fistula. I'll tell you what is high or low anal. High or low anal fistula is nothing but it depends upon the level of the internal opening. See here, internal opening is there. This is the external opening. If this internal opening is situated above the anorectal junction, see this is the anorectal junction, this curved bent end. Okay, above this, if there is an opening here, internal opening, and from that track is coming and it is opening here in the buttock. So that internal opening is above the anorectal junction. That is it is called as, it is termed as high anal fistula. Sorry, high fistula, or rectal fistula, where when if the internal opening, see here you can see it is situated below the anorectal, it may be at the dentate line or here below the dentate line here. So if it is here below the anorectal junction, then it is termed as low anal fistula. Okay, low anal fistula, low fistula in anum. So that is one type of simple classification. Another is the simple and the complex classification. See, it depends upon the course of the tract. See here you can see the course of the tract. Internal opening is here, okay, in the anal canal. External opening is here in the perianal region. Okay, how is the course of the tract? So it is not going through any sphincter. This is the internal sphincter, this is the external sphincter. It is not going, it is not piercing through the sphincters, so the sphincters are saved. Okay, so it is a simple fistula. So if you do surgery and if you remove this fistula in toto, excision of the fistula is done, your sphincters are not involved. So the continence may, once the sphincters are not involved, sphincters are not cut, so patient will have a good continence. That is, patient will have a good defecatory mechanism. Okay, so whereas in complex fistula, see here, so internal opening is here, and the course of the primary tract, the course of the tract is passing through the internal sphincter, external sphincter, and it is coming and opening here, somewhere here in the buttock, skin of the buttock. So it is piercing. So what happens if you do a surgery, if you excise this tract completely, what happens? You will be excising along with this tract, you are excising the internal sphincter and external sphincter. Once the internal and external sphincteric muscles have been removed, excised, what happens? Patient will have loss of continence. Continence mechanism is lost. Patient will be feeling that patient is passing stool. Sir, I am not able to control my feces. Sir, అది వెళ్ళిపోతుంది కింద నుంచి, నేనేమో పట్టుత్వం ఉండట్లేదు, నాకు విరోచనం వచ్చినా నేను పట్టుకోలేకపోతాను. When he comes and while passing, while he go to the bathroom only, there will be, he will be passing a pass feces over the floor. Okay, when he, before he go to the bathroom, so there will be loss of continence mechanism. So that's why it is a complex fistula. So it depends upon the course of the tract. So these diagrams are very important. So whenever a question has come, any question, if there are diagrams in it. You give a diagrammatic representation and give a small explanation that will be very much appealing to the examiner, and you will fetch good marks. Okay. Next is the parse classification. This is the classification what we use now. These are the general classification, but parse classification is the authoritative. Okay. So parse has classified into four varieties. See, intersphincteric fistula, transsphincteric fistula, suprasphincteric fistula, and extrasphincteric fistula. So among these, the most common is the intersphincteric fistula. Why? Because intersphincteric, see how a fistula is formed. I have told you cryptoglandular theory. So during in the intersphincteric region only, see here the in the right handed lower side you can see the figure. So here in the intersphincteric space there will be anal glands. Okay. So what happens? There will be fistula. See, this is the internal opening, this is the external opening. So how is the course of the tract? It is passing between the two sphincters, internal anal and external anal sphincter, and it is coming out through the subcutaneous fibers of external anal sphincter. It is coming out through the subcutaneous part of the external anal sphincter. Okay. And not only this is termed as the primary tract. This is termed as the primary tract. So from this center of the intragalli it has formed a primary tract. From here also, from this primary tract, what happens, there may be some secondary extensions. That is, it may pass above like this. It may pass above like this, and it may form a blind ending secondary tract here. It may form a blind ending secondary tract here, or it may form an abscess here. A secondary tract goes here and it may form high in the supralevator region, it may form an abscess, or this abscess or this secondary tract may go and join into the rectum to form another secondary internal opening. So there will be primary opening and the secondary internal opening at the rectum. So this is the secondary tract. Secondary tract may also come from the primary tract. Okay, that is the intersphincteric fistula. Next is the transsphincteric fistula. See here you can see both look the same, transsphincteric and intersphincteric, but there is a difference. See, this tract is going between the sphincters, intersphincteric, whereas this is the transsphincteric. It is passing trans, that is through the internal and external anal sphincter. See, here also it is passing through the external anal sphincter. Why it is not called trans? Because we doesn't, as per the Bayesian law, what he says is this external anal sphincter subcutaneous part. This is subcutaneous, superficial, and deep. So, if the subcutaneous fibers during surgery, if the subcutaneous fibers of the external sphincter has been some part has been cut, also there will be no much incontinence. Whereas the superficial or deep part, if it has been cut, there will be loss of voluntary mechanism. So he has not given much importance to this external anal sphincter subcutaneous part. So the tract is in intersphincteric is in through the intersphincteric plane, passing through the some fibers of subcutaneous part of the external anal sphincter. Whereas in the transsphincteric, see, it is going through the internal sphincter, passing through the deep superficial part of the external anal sphincter, but it is not coming in the intersphincteric plane. It is trans through the internal and external anal sphincter. Next is that for these two, this intersphincteric and transsphincteric, the causes are the cryptoglandular theory, intersphincteric gland infections. Okay. Next is the suprasphincteric, which is less common. See, suprasphincteric you can see here. Suprasphincteric, that is above the sphincters. See, this is the internal sphincter. This is the external sphincter, three parts: deep, superficial, and subcutaneous. So it is, this tract is lying above the sphincters into this, so that the internal opening is at the level of above the anorectal junction in the rectum, and the external opening is somewhere in the buttock. So suprasphincteric. So this suprasphincteric, the most common cause being the iatrogenic during a surgery for any anal canal disorders or a rectum. If you do a surgery and if you cause an injury, there may be a chance of fistula formation in the suprasphincteric region. Next is the extrasphincteric. See, extrasphincteric means it is not following a proper course. See this where it has gone. This extrasphincteric is, see, it is at the level of dentate line only, but see, it is passing through the internal sphincter and it is going supralevator and it is coming down. Okay, so it is extrasphincteric. It is extrasphincteric, not involving the sphincters. Okay, it is going above the above the levator and coming out and passing through the ischiorectal fossa and opening somewhere here in the buttock. So this can occur where there is a pelvic disease. There is a pelvic disease, or this is also some due to a trauma to the rectum. And in these, among these four, the best, the success rate, if you do a surgery, if you plan a surgery for among the, which is the best success rate, you see, if you have these four. See, intersphincteric and transsphincteric, if you do surgery, the success rate is good. Okay, whereas suprasphincteric and extrasphincteric, definitely if you do a surgery, there will be, the success rate is very low. The success rate is very low because it is involving most of this levator ani. Levator ani contains puborectalis, and it is the main, it is the part of the pelvic diaphragm. It is a part of the pelvic diaphragm. So if these are the suprasphincteric and extrasphincteric, if you do surgery also, you can tell to the patient that the chance of success rate is very less. The chance of success rate is very less. Whereas in case of an intersphincteric and transsphincteric, the success rate is very good when compared to the suprasphincteric and extrasphincteric. And to our surgical OPD also, most of the patient come with the intersphincteric or the transsphincteric fistula in an. Okay. Next is the clinical examination. So you will take a good history. So what are the anal symptoms? You will ask, how is his continence, whether he is able to defecate properly or not. Is there any good control? Can he able to voluntarily control the feces? Is he able to voluntarily control the defecation mechanism? So that you should ask. Any gastrointestinal complaints, because Crohn's disease is associated with a fistula nano. So you should be asking about some gastrointestinal complaints. And obstetric history. Is there any previous history of previously forceps delivery? Forceps delivery also causes some injury to the rectum, and it may cause suprasphincteric fistula. Okay, so you should be asking how is the delivery? Is it a normal vaginal delivery, or it is a assisted with some forceps applied while doing delivery? So it may cause some injury to the rectum and later cause fistula. Okay, and you should do, after taking a thorough history, you should do a perrectal examination if you have and a proctosigmoidoscopy if required. Okay, then what you should be noting is, when you put the patient in a jackknife position or knee elbow position, or usually we put the patient in a left lateral position, that is Sims position. We will turn the patient to the left side, left lateral, and you will ask the patient to fold the upper part of the leg. Okay, and you will see. So what you see is, you can see there will be an external opening. There will be an external opening. Definitely it will be there in case of a fistula ano. It can be an anterior or a posterior. The opening may be present in the anterior or posterior. That I will tell you later. Okay, the site of internal and external. Usually you will see external opening by inspection. Okay, but internal opening you can't see, but you can palpate with the finger. Internal opening, if you put a finger inside the anal canal and rectum, you can feel some induration, hard or button type. Okay, or button type or anal papillae like thing, small swelling or small ఎత్తులా ఉంటది అన్నమాట, కొద్దిగా గట్టిగా, or buttoning depression లాగా అనిపిస్తుంది. So that you can feel the internal opening, and you should be able to note the course of the primary tract. And if it is a low anal fistula, simple fistula, I have told you, if it is low anal below the sphincters, you can able to put a one finger, index finger inside the anal canal and thumb over the external opening, and you can palpate. You can palpate the fistulous tract. Okay, so that course of primary tract can be detected. Secondary tracts you can't detect clinically, but it can be detected by putting a proctoscope and by injecting some dilute hydrogen peroxide. If you put a dilute hydrogen peroxide through the external opening, there will be bubbles coming out from the internal opening. If there is one internal opening, or if there is a secondary tract which is opening into the rectum also, then you can see dilute hydrogen peroxide bubbles coming through two openings. So then you should suspect there is, apart from the primary tract, there is some internal secondary tract above the primary opening somewhere in the rectum. Okay, and you should see for any associated conditions. Okay, is there any inflammation of the rectum or not? Okay, so what polyps, any polyps are there, associated conditions, Crohn's disease, there will be usually there will be some inflammation will be there. Okay, next, and in Crohn's disease and tuberculosis, the classical is what is the differentiation between a normal fistula in ano and a Crohn's or a tuberculosis? There will be multiple fistula in ano. Multiple fistula in ano in the sense means you can see multiple external openings. You can see multiple external openings around the anus. In the perianal region, there will be multiple holes will be there. Then you should suspect two reasons. One is tuberculosis. First, number two is Crohn's disease. Okay, multiple external openings in a case of fistula and ano is definitive of a Crohn's or a tuberculosis. That should be, the tract should be removed and sent for biopsy for confirmation. Whereas a simple fistula ano, due to an sphincteric anal gland infection, there will be only one opening around the perianal region. That is the differentiating features. Okay, one, if you see the case of tuberculosis fistula and ano with multiple openings, you will never forget in your life. Okay, so what is Goodsall's rule? Usually this question will be asked frequently in the clinicals. Okay, what is, see the patient, see the patient is kept on lithotomy position. So this is a male patient, this is a testis, so this is the anal canal, sorry, this is the anal opening. So if you draw an imaginary line transversely, you can divide this anal canal, anal opening into anterior and posterior. So these round things are there, no? These are the external openings. Okay, see, as per the Goodsall's rule, if the external opening is situated posteriorly, if the external opening is situated posteriorly, always it will be a curved tract, and the internal opening will be in the posterior midline. Internal opening will be in the posterior midline, and it will have a curved tract. Okay, anything posterior to this line, if the external opening is there, see this dotted line, round dotted line is there. From this anal canal, anal verge to this dotted line, big dotted line is there, no? Outer big dotted line and inner dotted line. Inner dotted line is the anal verge, and outer dotted line is 1.5 inches, 1.5 inches from the anal verge. So opening within this 1.5 inches on posteriorly or beyond this 1.5 inches posteriorly, always it is a, the tract, primary tract is a curved tract which is opening in the posterior midline. The internal opening will be in the posterior midline. Whereas if the external opening, if it is present on the anterior aspect above the imaginary line, and if it is within the 1.5 inches from the anal verge, so it will be a straight tract, and the opening, internal opening will be exactly opposite to the external opening inside the anal canal. Internal opening will be a, and external opening will be opposite with a straight tract. And if this external opening on the anterior side, if it is beyond 1.5 inches, see here you can see the alphabet C, it is anterior, but it is beyond 1.5 inches from the anal verge, then the tract, the course of the tract is a curved tract. The course of the tract is the curved tract opening in the posterior midline. Okay. So that is good solved. So there are various investigations which we don't do routinely, but you remember this is the manometry, endoanal ultrasound, and MRI. Okay, manometry is for to note the sphincter length, the function of the anal sphincters, the resting stone, and the voluntary space. Endoanal ultrasound is to note the structural integrity of the sphincter complex. Okay, but among these, the gold standard is MRI, that you remember. Fistulography and CT scan are only for extra sphincter fistulas. So what is the surgical management? Surgical management is you need to remove the infection without damaging the continence mechanism. You need to remove the sepsis. So there are various procedures listed out here. You need to remove fistulotomy, fistulectomy, lift procedure, sit-on, advancement flap, and biological agents. So it will take some 10 minutes. Okay. So fistulotomy means opening, that is lay opening of the tract. So there is see here you can see there is an internal opening, external opening. A probe is passed from the external opening to the internal opening, and over this probe you give an opening. You open the tract. Okay. So after putting the probe, you should be able to see from the probe to here. You can see the external sphincter. How much external sphincter is involved? How much, if it is less than 30% of external sphincter is involved, then you should open. If more than 30% external sphincter is involved, then you should not do a fistulotomy. Better I will tell you. Okay. See here you can see if you put a probe here from the external opening, and if it is coming out here in the internal opening is here, so there is more than 30% here below the, see if it is a probe is here like this, so below the probe there is more amount of external sphincter is involved. In such cases, if you open, you will be opening the internal sphincter and external sphincter. For suppose if it is here somewhere, if you put a probe here, there is some 10% of external sphincter is involved. In such cases, you can perform a fistulotomy. Okay, that is what I have written here. And after opening, what happens? There will be granulation tissue in the tract. That granulation tissue is curated out with a scoop. Okay, after curated, the edges of the wound are trimmed with the scissors. And after that, you should do a marsupialization. Marsupialization is nothing but the edge of the wound is sutured to the surrounding overlying skin. See, multiple stitches are being placed. And post-operatively, daily dressing should be done. And if along with this, if there are any secondary tract, that should also be laid open. So in fistulotomy, there is also, if you do such thing, there will be some chance of incontinence mechanism also, because you are breaking some part of external sphincter fibers. They are breaking external sphincter fibers. So this is a age-old procedure. 600 years back also, this is in scriptures that fistulotomy is being done. This is an age-old procedure, and it is usually performed for intersphincteric and transsphincteric fistulas. So next is fistulectomy. See, ectomy means complete excision. This is best for simple fistula. See here you can see anus. Here you can see an external opening. See, this person has passed in from the external opening. A metal probe has been passed. Usually the metal is a copper metal. Okay, we usually use a copper, made up of copper. So it is from the external to internal opening. So what he does is, in fistulectomy, he will give an incision like this. He will give an incision, a tennis racket incision. See, you can see the incision, tennis racket, around the fistulous tract, and in toto he will remove whole of the fistulous tract. There, after that, there will form a big wound will be formed. That big wound should not be sutured. It should be daily dressed with hydrogen peroxide and betadine till granulation tissue comes, and it will be healed with secondary intention. It will heal by itself, and the wound will automatically get closed. Okay, here you are not applying any sutures. Okay, you give a racket incision and excise the whole of the fistulous tract. So what is lift? Lift is ligation of the intersphincteric fistulous tract. So here you can see this is the anus. See, this is the anus. See, this is the anus. This is the anal opening. See, this is the internal anal sphincter. This is the external anal sphincter. This is the external opening. Here is the internal opening. So, through this external opening, a probe being passed from the external opening, it will be passing through the external sphincter, internal sphincter, and coming out through the internal opening. In lift procedure, what you do is through the intersphincteric space. Here you can see a dotted curved line, curved dotted incision. That incision is given between the internal anal sphincter and the external anal sphincter. So because that space is avascular, you can go directly. So there you can see the probe passing in the intersphincteric space. That area in the intersphincteric region, the fistulous tract is being excised. How means you will put a clamp on the this side of this tract and another clamp over here, and you will transfix with the absorbable material, transfix the tract here. See, you can see here. So this is the tract which is seen in the intersphincteric plane. Here you will put a knot proximally towards the anal canal, and here you will put a knot towards the exterior. So this part of the fistulous tract in the intersphincteric plane is removed. Okay. So after that, after removal, this is the final picture. This is the final picture. So they have two openings, internal and external. So this part, this outer part, it will be draining the. You need to drain it. You need to put some hydrogen peroxide, and you put a scoop inside from the external opening, and you need to curate all the granulation tissue. This is one procedure, and here the main advantage is sphincter preserving. As it is going through the sphincters, you are not damaging or cutting the sphincter, so the continence is maintained. So it is usually used for transsphincteric fistula, and the healing rate is 40 to 95%. So another method is the set-on. Set-on is now so many of them are doing for transsphincteric and intersphincteric fistula. Set-on. Set-on is a non-absorbable and non-degenerative material used for healing of fistula. So there are two types of set-on: loose set-on and tight set-on. So difference between a loose set-on and tight set-on is loose set-on is non-cutting. So when you put a set-on from the external opening and come out through the internal opening, a suture material is brought from the external opening, and it is made to pass from the internal opening, and it is tied. It is tied. So within this set-on, there will be between internal sphincteric and external sphincteric fiber, but you will not tie the set-on tightly. So that is loose set-on. It is because it is not tightened, there is no tension on this encircled tissue. Encircled tissue is nothing but the internal sphincter and external sphincter. So it is only for the drainage purpose. It prevents the closure of the tract, and it helps in drainage of the secretions of the tract. Okay. Usually it is done for intersphincteric and transsphincteric fistulas, Crohn's disease, and done a prior procedure done before fistulectomy, advancement flat, and cutting set-on. So what is cutting tight set-on? Tight set-on is a cutting set-on. It creates tension around the encircled tissue, and it is both drainage and cutting mechanism. So it is also called as a staged fistulotomy technique. Staged fistulotomy technique is, that is, in fistulotomy you will cut the sphincters in one go, whereas in staged fistulotomy, in what set-on in this tight set-on do is, it will slowly cut from inner to outer side, slowly cut the sphincters, and after cutting it will form fibrosis. After cutting it will form fibrosis. Slowly it will come. See here, you can see in the external opening, internal opening, they have tightened the knot. Slowly it is cutting. See, it is slowly coming here, and it is slowly cutting. When this part comes and joins with the first suture here, so when it cuts, then you can cut with the scissors and remove it. Okay, here also it is a sphincter preserving surgery, and there will be no incontinence mechanism. That is the theory behind this cutting tight set on. Okay, this you should. I hope you have understood. Time is not there, but you just remember for your level. Just remember what is loose set on, what is tight set on. Between difference between loose set on and tight set on. It is a draining, it is a cutting, drainage plus cutting. It doesn't create tension, whereas it creates tension. It is usually used for a, okay. So this is another method where our Ayurveda the surgeons will be using. This is called Shara Sutra. Shara Sutra. Okay. This is also similar to the fistula what set on. What they do is same. They will pass a infant feeding tube. They will put a small hole in the infant feeding tube. Here he is giving cut in the infant feeding tube. He will pass from the external opening and it will be coming out through the internal opening. Through this cut made in the first figure, he made a cut. So in that he will pass this Shara Sutra thread. You can see పసుపు రంగులో ఉంది కదా yellow color రంగులో అది శారసూత్ర thread. He will pass through this and he will bring out and he will tighten. He will make a knot and tighten it. So what happens due to the tightening effect, same as the tight set on cutting mechanism, it will cut the sphincters. It will cut the sphincters and it will slowly heal by fibrosis, and later the thread can be removed after once it has been healed. This Shara Sutra thread, what it is made up of, it is made of some plant chemicals belong to Acaranthus and Euphorbia class of family. There are some chemicals. They will prepare some Ayurvedic medication and apply this apply that to a thread. So it has some chemical cauterization effect. Once this thread is within this fistula tract, due to the action of that plant chemicals, what happens, it will eat away the granulation tissue and cause fibrosis, and it will cause fibrosis of the tract. Okay, that is the mode of action. Still in this age also Shara Sutra are being performed by many surgeons. This actually it was devised by our ancient old sage Sushruta. Okay, Shara Sutra, and this is the final thing. This is the advancement flap. Advancement flap, you just remember these 5 points. What we do is in advancement flap is, say a probe is passed from external to internal opening, external and internal opening. Here he has given an incision. Here he has given a U-shaped incision below the dentate line, and that flap is raised. A flap is raised, that is mucosal flap is raised. So elevating a mucosal flap, number one, pouring out of an infected gland and internal opening. So here there will be some infection will be there, that you should scoop out. You should scoop out. You should scoop out, and this is the internal sphincter defect which has been closed with sutures. That is the third step. And number fourth step is the flap is closed. The flap is closed. It is multiple stitches have been present. Okay, this is the advancement flap. You just remember these 5 points. Okay? Next is the biological agents, but these are not at all useful nowadays. Nowadays studies are going on in relation the fibrin glue. They will inject into the external opening into the tract. Okay, that fibrin glue is not at all not at all what success. There is no success because it is getting early absorbed. It should not get absorbed because it is getting early absorption takes place. It has no action within the tract. Another thing is the small intestine submucosa porcine. Excuse me. So sorry. So these are the biological agents which have been used, tried, but with less success. Okay. Another thing is the dermal collagen from the pig. dermal collagen also being injected into the fistulous tract, but this is also the success rate is very less, and there are still studies going on. Okay, so this is the end of this topic. Okay, thank you.